Glendale Adventist Medical Center, they used to allow us to go over there and watch the patients get electric shock therapy. I mean, if you really had, if you were into, was it, well, yeah, if they were, I mean, if they were depressed or something like that, or, you know, it was better than a Monster Energy drink. Go over there, hook up those electrodes, and boom! Yeah, you know, you really kind of.
How long ago was this?
72.
They did that for what? What was the...
Mostly it was for depression or some mental disorders.
What is the point of scrambling the frontal lobe?
Well, okay, if you watch the movie called One Flew Over the Cuckoo's Nest, if people had violent tendencies.
Clockwork Orange.
Huh?
Clockwork Orange.
Yeah, Clockwork Orange. What they do, if you scramble the brain, then the person is just like a vegetable. I mean, the person just sort of, they don't do anything. They just sit there and smile all the time. So you've removed all their stuff. But depending on how far back you damage it, you know, normally most of this area, the frontal lobe, is where your emotions and memories and things are. So after they get through scrambling your brain, you basically don't know who you are, and you probably don't care.
Talks about it in the bell jar.
What's that?
Because Sylvia Plath had the electroshock therapy, and she talks about it in the bell jar. It's really scary.
One of my friends, his wife has some really severe mental disorders. They've done electric shock therapy here at Loma Linda on her. So they still do it.
How much electricity?
I'm not sure, but basically what happens is they put 2 electrodes on the temporal lobes, and then they put a device in your mouth. Yeah, so then when they shock you, it apparently creates the seizure. You know, so I mean, at least that's what it did in One Flew Over the Cuckoo's Nest. I mean, when we watched him do it, you know, at Glendale, I mean, it was pretty gruesome. It was pretty much medieval torture.
What would it do though?
Defibrillator on the head.
Well, I mean, what it does is it gets them out of that. I mean, I guess your brain gets into a vicious cycle, and so by shocking it, it's sort of like defibrillating your brain. Yeah. This Phineas Gage, as Greg mentioned, he was a railroad worker, and he set a dynamite charge, and when it exploded, one of the metal rails went through his brain, went through his head, like about a 2 foot.
Through his eye.
Oh, through his eye too, yeah. Didn't damage anything. The surprising thing is they took it out, he survived. I shouldn't say it didn't damage anything, because what happened is it went through his frontal lobe, and afterwards his whole personality changed. He lost everything. You know, he was like a supervisor on the train, foreman or something. Yeah, so as a result of his changing, his wife left him, got fired from his job, and he said that he would donate his brain to research after that. I have a few people I'd like to donate them to research myself.
Lobotomy.
Yeah, lobotomy. Yeah, I'd like to do that myself. Okay. Anyway, these are some things that, again, obviously, if somebody's had a stroke that's damaged the precentral gyrus, then they won't be able to move. If they've had one that's affected the postcentral, they won't be able to sense anything. They won't be able to taste anything. And these are some of the things you experience on patients that have had strokes. You know, my father-in-law hasn't really said anything since his stroke, so I'm assuming it's probably a mid-cerebral artery on the left side. Okay, but this Broca's area here, okay, this is your speech and language center. A lot of times, if that area is damaged, the person who's had a stroke, you know, you can talk to them. They don't understand what you're saying, and if they talk to you, they don't make any sense. I mean, my mom had a stroke, and she had, this area was affected. You know, she understood what I was saying, but to try to relate or talk back, she couldn't understand, or she couldn't speak. You know, what she said made no sense whatsoever.
Meaningful language.
Yeah, she couldn't pull up the right words that she needed. So, but she understood everything that I told her, but just, you know.
When I was talking on the phone really late one night, I was like falling asleep, and I said the most bizarre thing. It didn't make any sense at all. I was like, I don't even remember what I said. It was really funny. But does that have anything to do with that? Or? fall
Yeah,
asleep when it turns off.
That's probably just tired. That's, yeah.
What did you say?
I don't remember, it was like, get the tree out of the trunk. I'm like, something weird, I don't know.
Yeah, that's what I'm talking about. Yeah. But the other thing too is because that this is related to the speech area, you have one that sort of coordinates speech and language and integrates it. There's a nerve conduction that goes to the actual speaking muscles. And that's what this Broca's aphasia is. So if that area is taken out, the person says the person can still comprehend speech, but they can't speak or they don't form words. Does that make sense?
What's the other one, Wernicke's aphasia?
That's language interpretation, and that's in the temporal lobe. We're going to get to that in just a second here. But this is what happens with the frontal lobe being damaged. When they did this to people, this is what they were hoping for. You know, not as angry, you know, less emotion. You know, kind of like me when I give you your grades. You know. Never mind, okay. But this is the bad things that happen, you know, the epilepsy, you get seizures. And this is what happened to that poor gentleman. He had poor emotional responses, he became very violent. It had the opposite effect, so anyway, preservation of or uncontrolled repetitive actions. You know, people that like check the door 20 times before they leave, Tourette's.
OCD.
Yeah, obviously, yeah. OCD. Okay. The other thing that's, okay, well, take a look at this. Your sense of smell is also located in the frontal lobe. Okay. So this is, okay, we're gonna, okay, so here's your precentral, primary motor control, precentral gyrus. Okay, Broca's area for speech. This is all your emotions, or actually this area here. This is one of your sensory coordinating areas, especially for the sense of smell. So this is where you integrate your taste. Okay, you start putting the smell and the taste together. Because remember, how many flavors can you actually taste?
5.
It's 5, like sweet, sour, bitter, salt. Did you say salt?
Like water?
Sweet, sour, salty, bitter, quinine.
Yeah, for some reason the quinine doesn't stick with me. But anyway, if you don't believe this, you know, plug your nose when you go to an expensive restaurant and eat a steak. You'll hate yourself. You know, that's why you never go to a restaurant when you're sick and have a cold. You can't taste it. Okay, but here's the olfactory lobe down here. Okay, so this is all your frontal lobe area. Okay. And like I say, if you really want to read an interesting story about the brain, this Phineas Gage is an interesting person. Okay. The parietal lobe. Okay. I kind of like this term here, this proprioception. I'm going to name my kid proprioception. But basically, this is where it kind of puts all your senses together. And so notice the spatial awareness perception. So this includes both awake and asleep. I don't know if you're aware, but when you're asleep, your body is actually, you know, using information coming from tendons and muscles and sensors and everything to make sure. That's why if you've ever had too much to drink, you feel like the room is spinning, get the vertigo.
When your eyes are closed?
Yes. Yeah. Yeah. You learn very early in life not to drink too much. Okay. So that's what this part of the brain does. Okay, then we have the cortical. Okay, the somatosensory. So this is where the information coming in, the sensing information. This is where the parietal lobe decides what to do about it. So changing position or, you know, moving around. People aren't aware that they move around all the time, and that's because this thing sort of automatically takes over for you. So this is where the movement or, you know, like, does that kind of make sense? Everyone can that? So this is where you're standing and you realize that you're about ready to fall over. Well, rather than you thinking, oh, I have to make an adjustment and shift my weight, your somatosensory association cortex will do that for you. And then it will tell you to change your position a little bit so you don't fall over. Okay? But this one just tells you that this one tells you you're about ready to fall over. This one says, okay, we need to do something about it. So it sends the message because it's right next to the motor cortex, the central gyrus. So you can make adjustments very quickly. Okay, and then my favorite one down here, the primary gustatory cortex for taste. Remember all this stuff? No? Yeah. So, okay, so again, this is where the information coming in to your brain from all of the different points in your body, okay? This is where the body thinks about what it needs to do to react to it. And then my favorite, taste cortex. Again, if you were to look at somebody's brain, I couldn't identify. I could just give you a general location of it. But this one would probably be a little bit easier to look at than other types of things. But remember, this is what you're imaging when you do a perfusion scan. Okay? Okay. The occipital lobe, we know that it's vision and visual stimuli. Okay? So the first one, recognition of things, size, color, light, motion, and then your visual association area. This tells you, oh, that's a lion. I better get the hell out of here. Okay? Or that's dangerous. I need to get out of here. So you have not only something that lets you know that you're seeing something, but you also have an area of the brain that tells you to do something about it so that it coordinates it with other areas. So this is where you actually see things in the back of your head. So don't bash the back of your head.
Why is it back in the back of the head and not like close to the eyes? I
I think you probably needed a lot of room to run the nerves, because they have to bifurcate, and I don't know. I think when God was putting us together, He said, well, God said, oh, I've got all these extra parts, what should I do with them?
Stick them back here.
Yeah, put it back. You know, I don't know. I mean, I have no, it works though. And what's really interesting is that everything that we're looking at is a reflection. That's what really is kind of interesting.
Upside down.
It's upside down on your opposite side, and it's a reflection. So you're seeing the light that's reflecting off of objects. And what's even more interesting is your color is only 3 colors. But by mixing them, you get all the other different colors. Okay, so this visual association area. So here's where you see something. That information is transmitted to here. Is that the brain will say, okay, is that something dangerous, or is there something that I need to do? Because that's the visual association area. Does that make sense? Okay, the olfactory lobe is located in the temporal lobe, as well as hearing and language. Okay. And this is, when you're talking about memory, this is where the memory actually kind of starts. It goes through here. And a lot of the basal ganglia and limbic system apparently have things to do with your memory. And then if you smell, it's your olfactory lobe. Okay, there's your Wernicke's. The Wernicke is only on the left lobe, left temporal lobe. Okay. So here's your hearing area. That's why people have selective hearing. Honey, I told you to go clean the car 10 times. For you people that are married, you can appreciate that. When you're dating somebody and they say, oh, my car's dirty. No problem, honey, I'll go wash it for you. But after you get married, and am I right, Monica?
Now it's a problem.
Yeah,
Not really.
honey,
Kind of.
the car is dirty, can you wash it for me, please? Well, let's see, there's a football game on right now. Okay. Here's Wernicke's area. Okay, this is your language center. And then here's your smelling center here. Like I said, I'm not going to be testing you on that, but just realize that when a person has an injury or a stroke or something, and these areas are affected, these are the symptoms you're going to be dealing with. And normally this would be like a mid-cerebral artery problem. Okay. This is the other thing here, the communication between the Wernicke's area to the speech center. If there's any injury to that, that's why they said sometimes a person can still understand what you're saying, but they can't communicate it to you. Okay, those nerve tracts are damaged, and you know, there's a tremendous amount of swelling that occurs also when you have a stroke. Tremendous amount of intracranial pressure. One of the things that we didn't stop and talk, or we'll be getting to it, but when a person has a stroke, one of the ways we can tell that, besides the obvious, you know, lack of movement on the face where the side of the stroke occurred, but also on the opposite side, but also the pupils. When a person has a stroke, the side that had the stroke, the pupil dilates because there's increased intracranial pressure on the cranial nerve, especially the third cranial nerve, the oculomotor. Yeah. And so what happens is that pupil dilates.
The face and the drooping face, that's opposite as well to the side that had the stroke, isn't it?
If I had a stroke on the left side, my left side would droop, this pupil would be dilated, but my right side would be paralyzed. So.
It's dilated eyes parasympathetic or something.
I don't think it's either. I think it's autonomic. Well, actually, I know that when a cat or something is getting ready, I think when it dilates, it's sympathetic,
Yeah.
and when it shrinks, it's parasympathetic. And if it doesn't respond, then you're going to jail.
It dilates to like let more light in to see what's happening
Yeah.
during that fight or flight.
So
Okay.
dilated sympathetic.
Sympathetic.
The third, like I said, this is, you know, so this is sort of a summary of everything here. And then this is, I'm not going to do this to you guys. Okay?
Thank God.
But, you know, having to understand what all this stuff is, this tells you what everything is here, though.
Okay.
So, the central sulcus, okay, the frontal lobe. Okay. This is something you can go through and, you know, you can kind of just see what everything is. What's more important to us is going to be the stuff on the SPECT brain images. Okay, and again, even with that, those are horrible images.
Yeah, you can't even like make out what part you want.
Yeah, I wouldn't do that to you guys. But I mean, you should have an idea of where, you know, some of the major players are. And these are the cortical regions here. So, you know, to me, I mean, I can see that is the central gyrus, but that's about it.
Where?
Can't see that. This little blob here, go with that.
How do you know it's that one?
Well, because it's got the fissure on the other side, the central sulcus is here. I just kind of look for the middle of the brain. But yeah, you know, unless I'm looking at a deep fissure. So which one of those would be Broca's area?
B.
Okay. And then Wernicke's area.
Oh.
Never mind. Okay. So anyway, this is something that, you know, if you get really bored, you can't sleep, go through this a few times and it'll put you to sleep. Okay. But I mean, honestly, looking at that, I wouldn't be able. I could give you an idea, but I couldn't. You know, normally in surgery, they poke those areas, they give them a mild electric shock and see what happens.
Seriously?
Yeah.
Even the
Things
doctors.
come up, they move.
Did you ever see that commercial that they have for?
Yes.
That is so funny when the guys typing on the computer, surgeons there. Did you see that?
Velocity or
Travelocity.
kayak?
Kayak.
Kayak, yeah. Yeah, that was great. And you'd have to work in the hospital to appreciate it. But, yeah. Have you seen it?
No.
Okay, there's a commercial where the brain surgeon is, you know, working on the guy, and You know, and he's making him do all this stuff with his hands.
Make him search for it.
Yeah, making him search for a vacation site. He says, well, I don't have time for it. And then he does, it's really
That's
cute.
high.
Okay. Anyway, so this is just, you know, these are some things that you should be aware of, but, like I said. Okay. This is a picture that I came across that, you know, it basically shows the relationship of the primary motor cortex. This is everything that it does. And this is the location of where it does it. Okay. So this is one half of the hemisphere of the brain. So here's your longitudinal fissure. So moving from the longitudinal fissure out, you know, your toes. So basically, as you work your way around the hemisphere, you get to the, you know, just different areas. Okay.
Yeah, the picture of that little man.
Yeah, somewhere in there. Cerebellum. Okay. And the cerebellum, I put down here the main things that I'd like you to do. This is also in the handout too. But basically, coordination. You know, like I said, this guy is able to process how you're standing and when you're going to fall over, so it's able to correct it. And then also it has the cranial nerves in it. So the cranial nerves are kind of important, so we'll talk a little bit about them. Again, just a little bit more information about it. The other thing is, notice that the principal functions include eye movements, limb movements, posture, balance, motor decision making. You know, so in other words, if you're going to move an arm, how does your body know to move the left arm and not the right arm? Because both the nerve tracks are actually pretty close together. What else? And then this is another little thing here. I figured that since some of this stuff shows up abnormal, you know, the corpus callosum we talked about, that's the limbic system. Vermis, the caudate nucleus, I'm sure you've heard of that. The caudate and the putamen, or sometimes, well actually the putamen and globus pallidus are linked together here. These are the ones that kind of control your movements when you're asleep.
That's what the DAT scan stands for.
Yeah. Well, sometimes these things will pop up in certain disease conditions. When you're looking at brain scans, especially brain perfusion, you'll see these things light up. But I threw that in there because you know, they're going to be including some cross-sectional anatomy on your warts. At least that's my understanding. Okay, so I wanted to throw some of that stuff in there. This is, again, these are what we call the basal ganglia, or most of these are just the basal ganglia here. It looks like a ventricle, but it's not. Okay, kind of wraps around the corpus callosum. They call it the corpus striatum. These two things together are sometimes called the corpus striatum. And again, these things also help coordinate not only unconscious but also conscious movements, proprioceptive type stuff. And then over here we've got a couple of little guys. These belong to the limbic system. Limbic system is your emotions. I mean your primal emotions. You know, like when you kill your significant other because you want their hot dog. You know, that type of stuff. So these are the real primal things here. I've listed the thing here. These are the basal. The amygdala is not part of the basal nuclei. Okay, this is actually part of the limbic system. Okay, but since it was in this picture here, I wanted you to kind of see the relationship of these guys to each other. Yeah. Like I said, where it says associating memories formed through different senses and linking them to emotional states generated in the hypothalamus. So every time, you know, you were eating hamburger and somebody punched you in the shoulder, you got really angry. So every time you smell a hamburger now, you get angry and want to hit somebody. That's because of this. Yeah. That,
behavioral.
okay, I'm not on a roll for analogies today, guys, I'm sorry, okay? It's the best I could do under the circumstances. But here's the caudate nucleus here. You can't see it very well on this one, but here you can see the corpus callosum. We're going to see a few other familiar things here. Okay, isn't that cool? Looks like I have a poster of this. Okay. Now, this is coming back to our old, remember these? The thalamus, the hypothalamus, the pineal body, remember those? Where did those, well, the thalamus we didn't talk too much about. The hypothalamus? Okay, yeah, remember we said the hypothalamus, it has, well, let's take a look at the thalamus. Okay, integration of all sensory impulses. Okay, yeah, then the hypothalamus, remember this is one that measured all of your hormone levels and released TRH, which went to where? Where did the TRH go? Okay, anterior pituitary. Okay, but also remember that this is also what we think happens when people, you know, when you have a fever, it's your hypothalamus that's creating the fever. And when you take an aspirin to lower your temperature, actually, this is like a thermostat. Okay, so your hypothalamus knows blood pressure, hormone levels, emotional and physical homeostasis.
Hypothalamus secretes a,
What is it?
what secretes ADH?
Pituitary. What?
Just,
Yes.
Close.
Huh? What did you get wrong?
what secretes ADH?
What secretes ADH? Do you know what it acts on? What does ADH act on?
Just the collecting device.
Okay, just the collecting does. Okay. And then remember the pineal body. You know, I can remember up until the 70s, we would take an X-ray of the skull. We would see it calcified, or sometimes or not. And remember, this is mainly for sleeping. Yeah, melatonin.
That's why older people suspectively can't sleep as well, because it calcifies, right?
Yeah. And they can't sleep. Okay.
Oh, is that why those are
Yeah.
One of the reasons.
That's one of the reasons. I don't sleep because I get PO'd at evening. Okay, thalamus in the brain.
Really?
What is that?
Would it be the
That gets to
opposite?
you that way?
When you get angry,
No, you can't sleep because you get pissed off at people. That would
Yeah.
not be good.
you know, vengeance is mine, saith the Lord, but that's why he
That's
subcontracts.
served cold.
Yeah, well, then he subcontracts. Okay, this is the important area that we had talked about before, you know, the thalamus. Okay, so here's your coordination center for all your sensory information. I hope you don't mind that I put these in here, because you will see these on sagittal views of your perfusion studies sometimes. Okay, here's the corpus callosum here. Okay, remember that's going to look white. The dark stuff here is your ventricles with cerebral spinal fluid in them. Here you can see the fourth ventricle here. Here's goes going around the spinal canal. And remember, it comes back up into the basal cisterns. Okay, hypothalamus. You can see that there's a little bit of an area there. Here's the, what is this area here?
Pons?
Yeah, never mind. It's part of the sphenoid bone. Yeah, but see, remember that MRI doesn't show bone, so which is probably a good thing. Okay, and then here's our pituitary. Okay, so this one actually sits on the sella turcica. Okay, but I just thought, and then I put the limbic system here, so that's why, you know, again, these things mainly light up, especially in, you know, when you do a brain perfusion or seizure scans, or if you're doing perfusion or PET scans, sometimes you'll see these things. One of the, I would really like to stress to you when you aren't imaging the brain or anything else, make sure that the patient is completely straight. They're not looking off to the side, not tilted, anything like that, because it really screws this stuff up. So even though you have a patient who's gorked out, do everything you can to make sure that that head is as straight as possible. Because basically, the only way we can diagnose this is by comparing the two sides. In other words, nuclear medicine, we rely on symmetry to tell us if something is abnormal or not. So if you have the same amount of activity on both sides, it's probably normal. But when you either have too much or not enough, then it's abnormal. Okay. Then here we have the medulla. And again, this is most of the primary body responses. So like you said, the breathing, the vital signs, things like that. It makes them go, but it's not, it sends the signals out to keep you breathing and stuff, but sometimes there's a higher source that sends a message to it to send out and breathe. Remember, we've got sensors in here. I put down all the stuff that's in the brain stem. Yeah. Well, you said on old Olympus tabletop, a Finn and German viewed some hops.
I know a different one.
Yeah, I know, don't say it.
I know that one.
We can't repeat it.
Oh.
Okay.
No, it's a little thing. Yeah, too touchy.
Okay, on this one here, remember that you're going to hear the term cerebral peduncles? Okay, these things light up. And I think if you look at our study there, you'll see the peduncles lighting up. Okay, and again, we should have the same intensity. Notice this connects the cerebrum with the brain stem. Okay, then we have the cranial nerves. Again, the ones that are, all of them are important, but the optic, or the oculomotor, okay, that's one that we use as an assessment tool. But for the pupil, you have the optic nerve, and sometimes the optic nerve gets wiped out because of trauma or tumors. Okay. I'm trying to think which other ones were important. You have the acoustic and vestibular nerve, okay, it's for hearing. When this one gets knocked out, the patient has vertigo. In fact, here Loma Linda we used to do what they call an eighth nerve series. You would take a certain radiograph of the skull. We could actually measure the internal auditory canal. When it goes to the thick part of the sphenoid bone, you could measure it and see if the patient has like an acoustic neuroma or something else going on there. All of these other ones here, glossopharyngeal, remember when the patients have a stroke, that gets knocked out. Vagus nerve, very important, parasympathetic. You stimulate that one and everything slows down, right? I put down here where it's located, so like the vagus nerve is located in the medulla. It has both sensory and motor functions. So when you're swallowing, talking, heart rate going down, slowing down, peristalsis for digestion, that's a motor function. But it also, when you have a sore throat, larynx, okay, it has sensory properties there. So like I said, I know this is probably old hat for most of you, but it's probably not a bad review, just to keep in mind here.
Trigeminal neuralgia, fifth one.
Yeah.
Coworker has that.
Also Bell's palsy.
What's that?
Bell's palsy is a viral, inflammation of one of the nerves, and basically,
Drooping.
yeah. A lot of times we don't know if a person's had a stroke or if they have Bell's palsy. But this one I think is pretty important here. The autonomic nervous system, including breathing. So I put this one in here. It has the pneumotaxic and aponestic respiratory centers. So one tells you to breathe. The other one tells you not to breathe too much, because otherwise your lungs would explode. It says central chemoreceptors monitor CO2. Those are the ones that are located in the medulla. Remember that you have the other chemoreceptors that are in the carotid artery and the aorta that measure oxygen levels. So both of those, if the carbon monoxide levels get too high, the medulla tells you to breathe. Greg yawning right now, that's his medulla. Because when you yawn, your carbon monoxide levels, you get carbon dioxide levels.
Or too hard.
Yeah. When your carbon dioxide levels get too high, your body will tell you to yawn. That's what it's for.
Why is it
Not that you're not.
contagious then? Like you see someone, or
Yeah.
someone by you does it, and you look over, they're yawning, and
Because
you just yawn.
I don't know, you're tired. You're all tired.
There you go.
Because we're
It's
breathing
probably,
out all the CO2 and.
yeah.
Yeah, you're getting carbon dioxide poisoning or something. Too many soft drinks with CO2 in it. But this is an important one here. This is one we talked about with lung scanning. And again, this is also why patients that are COPD cannot receive oxygen. Okay? Because the CO2 in the medulla has been knocked out. And if you give them more than 3 liters of oxygen, it turns off the carotid and aortic sensors, so they don't think they have to breathe. So they put them into respiratory arrest. And then when the nerves leave the brain, you notice 31 spinal nerves broken down into 8 cervical, 12 thoracic, 5 lumbar, and then 1 coccygeal.
Why 8, but not 7?
Got an extra one up there that comes out before the occipital Atlanto junction. Yeah. Well, you've got 7 cervical vertebrae, but you've got one that comes up before C1. You've got one at C1, C2,
Oh,
C3,
so nerves.
C4.
Yeah, there's the nerves, not the bones.
They're the nerves, yeah, they're not vertebrae. And then lastly, a little picture of the medulla. I think I want the ponds here too. Next week, we're going to start with CSF. And in the handout that I sent you, we're going to be talking about where CSF is formed, how much of it, where it goes, how it's supposed to go. And on chapter 10,